Many patients admitted to the ICU after a cardiac arrest have hypoxic ischemic brain injury, which often leads to persisting coma. Myoclonus or status myoclonus is observed in about 20 to 30% of these patients, while truly epileptic seizures are less common. Both status myoclonus and electrographic status epilepticus are regarded as an indication of severe brain injury with usually a poor prognosis, but a good recovery has been reported. In daily clinical care, there is often uncertainty about the diagnosis, usefulness of additional diagnostic tests, and possible methods of treatment. Clinical recognition and differentiation. Sedative drugs are usually administered for the first 24 hours or more after cardiac arrest. When sedatives are phased out, short-lasting or repetitive muscle jerks in face or limbs may appear and increase in intensity. Myoclonus is defined as sudden, brief, repetitive, irregular, and involuntary jerks of muscles. Postanoxic myoclonus is mostly seen in the face, trunk, or axial extremities and can be triggered by touching the patient or clapping the hands. Postanoxic myoclonus can originate from the cerebral cortex or from other parts of the brain. There is substantial interobserver variability regarding assessment and classification of postanoxic myoclonus and postanoxic status myoclonus. Postanoxic status myoclonus must be distinguished from status epilepticus, because the treatment implications are different. In classical epileptic seizures, jerks are highly rhythmic, whereas postanoxic myoclonus and postnoxic status myoclonus are characterized by irregular jerks. EEG can contribute to discrimination between postanoxic status myoclonus and status epilepticus. Epileptic seizures are accompanied by epileptiform discharges, whereas the EEG in postanoxic status myoclonus is highly variable. A rare type of postanoxic myoclonus is the Lance-Adams syndrome, where patients have mainly action-induced myoclonus and are awake. With Lance-Adams syndrome, the prognosis for recovery is generally good and there is no place for treatment limitations. Electroencephalography. The electroencephalogram, or EEG, measures electrical potential differences between pairs of scalp electrodes, primarily resulting from fluctuating postsynaptic currents of many cortical neurons arranged in parallel. EEG activity mainly reflects cortical synaptic activity, that is, the process by which neurons communicate by chemical signaling. Since cortical synaptic activity is very sensitive to hypoxia or ischemia, the EEG is highly sensitive to detection of hypoxic encephalopathy. EEG activity will be disrupted within seconds after cardiac arrest. EEG bedside monitoring is relatively simple and therefore possible in most hospitals. However, EEG interpretation needs specific expertise and interobserver variability has been described in patients after cardiac arrest. To diminish indistinctness and misinterpretation, the American Clinical Neurophysiology Society developed nomenclature with strict directives for interpretation of EEG registrations performed on the ICU. Prognostic value of EEG. A wide spectrum of pathological EEG rhythms can be observed after cardiac arrest, ranging from complete suppression of brain activity to abundant pathological bursting. Reappearance of continuous, normal amplitude activity within 12 to 24 hours after cardiac arrest is strongly associated with a good neurological recovery. Persistent suppression for over 12 to 24 hours is a reliable predictor of poor outcome. Suppressed EEG with bilaterally synchronous discharges or high-amplitude bursts predicts a poor outcome irrespective of timing since cardiac arrest. Many different EEG patterns have been evaluated and their value for prognostication was summarized by Sandroni et al. Based on these established predictive values, early EEG is recommended by guidelines for prognostication of comatose cardiac arrest patients. EEG for diagnosis of epileptiform patterns. 1. The large variety of possible epileptiform EEG patterns has been categorized as rhythmic and periodic patterns, RPP, by the American Clinical Neurophysiology Society. 2. RPP that resemble or meet criteria of seizures or status epilepticus have been reported in up to one-third of comatose patients after cardiac arrest. 3. Unequivocal seizures and electrographic status epilepticus are rare, whereas other rhythmic activity, such as generalized periodic discharges or rhythmic delta activity, is more common. 4. Without EEG monitoring, approximately one-third of cases remains undiscovered due to the absence of clinical signs of epilepsy. 5. Isolated discharges hold no predictive value, but ongoing RPP for over 30 minutes have been associated with case fatality rates of 80 to 100%. 6. Muscle relaxants may be necessary for optimal EEG registration in patients with myoclonus, since muscle activity may cause artifacts in the EEG. For optimal recording, high-dosed sedative medication should be avoided, as this can suppress epileptiform activity in the EEG. Treatment with anti-seizure medication, yes or no? It is unclear whether all rhythmic and periodic patterns, RPP, represent truly epileptiform activity, which can be treated with anti-seizure medication to improve outcome, or merely severe brain damage, in which treatment is futile. Uncertainty about the efficacy of treatment is reflected by debate between experts in the field, as well as by large practice variability. Surveys have indicated that approximately one-third of neurologists in Europe and the US uses stepwise anti-seizure treatment to suppress all epileptiform activity, one-third uses these medications in a non-standardized way, and one-third does not use anti-seizure medication, because of presumed futility. The 2021 treatment of electroencephalographic status epilepticus after cardiopulmonary resuscitation, Telstar, trial is the only randomized controlled trial aiming to assess whether status epilepticus treatment improves outcome of comatose patients after cardiac arrest with epileptiform patterns on continuous EEG. Complete suppression of all RPP for as greater than or equal to 48 consecutive hours was achieved in 56% of patients in the intervention group versus 2% in the control group. Still, there was no overall difference in the risk of poor outcome between the intervention and control groups at 3 months after cardiac arrest. Predefined subgroup analyses showed marked heterogeneity across subgroups of EEG patterns. In the large subgroup of patients with generalized periodic discharges, the intervention group had a smaller proportion of good outcomes than the control group. Conversely, for the small subgroups with patterns closely resembling electrographic seizures or status epilepticus, outcomes in the intervention group were better than in the control group. Some critical remarks have been raised with the Telstar trial, including high overall rates of death and poor neurological outcome, use of sedative medication in both intervention and control groups, and the trial being underpowered for the subgroup analyses. The Telstar data indicate that the chance of benefit of anti-seizure treatment in patients with generalized periodic discharges is very small. Otherwise, prolonged anti-seizure treatment of patients with patterns resembling or meeting international criteria of electrographic status epilepticus may improve outcome. In daily practice, the decision to treat the RPPs or not may be influenced by other factors than the EEG, such as age, comorbidities, and functional activity before admission. Furthermore, results of other diagnostic tests to predict neurological outcome can provide direction to treatment decisions. Choice of anti-seizure medication. Postanoxic myoclonus, in contrast to postanoxic status myoclonus, usually resolves after several hours without any specific treatment. When it is decided that treatment of seizures or status epilepticus is warranted, the general advice is to treat as soon as possible and target suppression of all epileptiform discharges in the EEG. In the Telstar study, treatment in the intervention groups was based on guidelines for clinically overt status epilepticus. This included stepwise treatment with rapidly increasing dosages of anti-seizure and sedative medication. Based on the results of the randomized controlled trial by Kapper et al., it seems reasonable to initiate treatment with either levetiracetam or valproic acid instead of phosphenotoin. As extensive treatment of status epilepticus after cardiac arrest is not very often applied, the use of a standardized, local approach is advised. The effect of treatment has to be evaluated on a daily basis. Furthermore, it should be discussed within the treating team and with the family members whether continuation of treatment will lead to a desired outcome. Take-home message. Myoclonus, status myoclonus, and electrographic status epilepticus are signs of severe brain injury in comatose patients after cardiac arrest. The Telstar study has shown that stepwise treatment with sedative and anti-seizure medication will not lead to an improved outcome of unselected patients with RPPs. In the small subgroup of patients with an EEG pattern closely resembling electrographic seizures or status epilepticus, Treatment might lead to a better outcome, but the evidence of efficacy is weak. In case of anti-seizure treatment, levetiracetam or valproic acid are reasonable first-choice anti-seizure drugs.